welcome. I really appreciate it. I'm thrilled to be able to come back live and talk about something that I'm personally very passionate about. And, you know, I guess anyone who signed up to join today must be passionate as well. So I hope it is well worth your time. I'm just going to get my screen set up to share. Switch over to here. And I just want to confirm that that is coming through. Okay.
Yes, everybody can see it.
Awesome. Wonderful. Well, again, so yes, thank you for that warm welcome. This is who I am and what we'll be talking about today. And in order to understand disability, it's important to understand what normal aging looks like. And as a geriatrician, you know, I've devoted several years to, you know, studying and understanding this. But as my career has progressed, I spent more and more time studying the nature of mistreatment and incapacity and kind of these cognitive and psychiatric and sometimes neurologic implications and causes of disability. So we'll touch on kind of what is normal and what is not, and then how that relates to kind of the guardianship and legal systems. I don't have any exciting disclosures. All right, so since you're joining us today, I wanted to, as stated, spend some time discussing what normal aging looks like in an adult human. Many of us have children and we see what looks like to grow into an adult, but later on in life, many of us are blessed with the blessing or the curse, depending on how you view it, of becoming an older adult as well. And there's a lot of changes that are both normal, but many of them also can be pathologic. And so I'd like to explore that and see, you know, what the prognoses are of these associated disabilities and how best to support older adults. A big part of geriatric medicine and the study of gerontology is learning how to, you know, promote healthy aging in place in the settings that they want to age in. And when that goes awry, how we as people who are interested in the well-being of older adults can facilitate their care. So what is normal aging? So what I get a lot is, isn't aging just getting older? And to some extent, yes. I mean, you know, that is exactly what happens. We progress through kind of a normal life phases, starting from when we're inside of our mother, progressing through infancy and childhood, through our terrible teens, eventually reaching adulthood. But what kind of happens on the later parts of adulthood? Is it just that we become older? Partly. So what we do when we age, it is something that is predictable. It's a progressive change in our body and our function. Some of it is related to genetic features. A good bulk of it is environmental, how we did taking care of ourselves. You know, did we smoke, did we drink, or did we exercise daily and eat our fruits and vegetables? A little bit of it is luck. Luck sometimes is kind of the result of genetics. Some people are just blessed with family members and good genes that live on and on and on, and we gain those benefits whether we did all the right things or the wrong things. Some of us just live longer than others. But as you get older, genetics play a larger and larger role. Again, there are people who, as I heard one of my older adults say, are pickled in smoke. They smoked their entire life, they drank their entire life, and yet they're still, you know, in their 90s or even early 100s, while those of us who, you know, burnt the rubber of our treadmill are struggling to make it to 80. So there definitely is a genetic component that matters more as we get older. One of the beautiful things about geriatric medicine that I really like is when I see a patient, just because someone's 70, sometimes I get a 70-year-old that I have 90-year-olds that look worse than that, or that look better than that 70-year-old. Some 70 looks very poorly. Other 70 are bodybuilding, running marathon champions, and that put me, myself, to shame. So I never quite know what I'm going to see when I see a patient. There's a wide range of, you know, what aging looks like, and that's very exciting. But all the things that go into that are complicated. Some of them are purely based on your body, the physiologic changes of just having lived in your body a long time. Some of them are psychological changes that have to do with the changes in relationships as you get older. Some are cognitive changes simply related to an aging brain, some of which are normal and others are not. And then, of course, social changes. You move into retirement, hopefully, if you're lucky, you have changes in who's at home with you. Your children grow up and leave. Maybe you become a grandparent and are involved in raising your grandchildren, or maybe you become isolated. All of these things impact how our bodies work. And eventually, if you live long enough, all of your body will be impacted by these changes, but it doesn't happen in a predictable or a synchronous way. If you drank more or smoked more, you might have earlier problems with your liver and lungs than someone who didn't do those problems. But eventually, everyone's liver enzymes, will slow down at processing medications we take, for example. So it's not always clear how it's going to happen, but it does happen if we're lucky. And some of the big changes that we see are changes kind of in our body's rhythm. The way our bodies process, for example, like circadian rhythm is changed. We need different amounts of sleep as we get older. The type of sleep, is it deep sleep? Is it REM sleep, that rapid eye movement sleep? Is it a lighter sleep? Those things change. Our temperature control changes. All of these factors influence how we sleep, as do our many hormones. Women, of course, go through menopause, and while there's no kind of discrete hormonal, change that occurs at a particular phase of life for men, we do see changes in testosterone and other hormone in men too. We see changes in your thyroid, our growth hormones, our stress hormones. So there's a lot of changes in the rhythms that our brain releases chemicals to influence the body's hormones. The complexity of our body changes. We overall have less response to stress. There's something called the positivity bias that develops as you get older. You tend to focus, hopefully, on the more positive aspects of life, and the things that are negative that younger adults fixate on, genetically, biologically fixate on, not because of anything really wrong necessarily with a younger adult, but older adults don't focus on that. The change becomes more positive. You spend time doing things you enjoy preferentially. And then the actual physiologic complexity of your body changes. Your heart rate doesn't go up as much when you exercise. There's less variability in your heart rate and your blood pressure. Your brain waves are more steady. Again, less kind of stress responses to things. You just kind of level out a little bit. And then this concept of homeostasis, which, if I am correct, was actually coined by a geriatrician who trained me, Dr. George Taffet, over at Baylor College of Medicine in Houston. And homeostasis is kind of a pithy way of saying the opposite of homeostasis. Homeostasis being equilibrium and stability, homeostasis is a narrowing of our body's ability, a limiting of our body's ability to respond to stressors. And this all happens due to reduced physiologic reserve. So one way of thinking about this is how when you were a child and you got a cold, it seems as if children bounce back from colds, sometimes even almost overnight. I'm always in awe of my 3-year-old and my 1-year-old for how quickly they get over a cold. And even I'm 35, my husband and I will linger with that cold for days on end. But then you think about how when another 30 years passes, how when you're 65 or 75, it can be really hard to recover from just a simple, cold or respiratory infection. Pneumonia. I had pneumonia when I was 18 years old. I didn't have to go to the hospital. I got a shot of antibiotics at the doctor and I was back at school probably 2 days later. I don't think even twice as old now, that would be the case. Because as you age, your vulnerability to disease and disability increases with a simultaneous decrease in your ability to bounce back from these infections. And that's many factors go into that. And it's kind of outside the scope of, this presentation, but suffice it to say, immune changes and changes in frailty versus kind of that hardiness change over the course of life. And frailty, medically speaking, is a point in an older adult's life, or really anyone's, but specifically an older adult's life, when they really lose the ability to bounce back. Any small trigger to their body, to their mental well-being, can cause them to fall off the proverbial precipice. So instead of bouncing back from a case of pneumonia and going back to school later that week, they're going to wind up in a hospital. They might even be in an ICU on life support or a breathing machine from the same pneumonia that was no big deal for me to handle as, you know, a young adult. And you just lose this physiologic wiggle room. So this is an illustration, a diagram kind of showing what I was just speaking about. And unfortunately, as you get increasingly frail, increasingly disabled even, adverse outcomes to smaller and smaller stresses become increasingly common. And unfortunately, there's a bit of a cyclical or circular effect of, if you become ill, you wind up in the hospital, you leave weaker than you were, which makes you even more likely to become ill again, wind up back in the hospital, and get progressively weaker each time you go around this kind of unfortunate circle. And this is something that we see. It's kind of a terminal geriatric spiral. I don't think it's called that officially, but you know, that's how geriatricians tend to conceive of this. And all of these things can result in increasing disability, both cognitively and physically. Some things you may have seen in your own clients, your own family members, or perhaps even in yourself. One such example of this is delirium. This is when your brain can't handle the physiologic stress and you become confused and disoriented, whether that's due to, say, a pneumonia, a urinary tract infection, a heart attack, or just taking, you know, a medication that doesn't agree with you. You can become profoundly confused unexpectedly, or just because you're in a different place. Simply being hospitalized alone is enough to cause this confusion. It's very disorienting to wake up or struggle to sleep in a beeping bright hospital for days on end. And so delirium is a geriatric emergency. It's equivalent to a heart attack in its severity. It carries a very high mortality. It's not just simple confusion. So it's an example of when the body can't compensate to the stress. Similarly, and probably more relatable, is kind of the physical manifestations of septic shock, which is when the heart and the vascular system of the body can't handle overwhelming infection due to a big inflammatory response. The body uses inflammation, getting a fever, for example, to fight infection. A lot of bacteria can't handle the heat, literally and figuratively. So raising the body's temperature helps fight that. But sometimes the body kind of goes too far, goes too extreme, and we have what we call like circulatory collapse or septic shock, when the body can't handle this response. The body is also physically less equipped. The heart is like less compliant to stress. It can't handle a fast heart rate for as long. Blood pressure dips. Many changes happen, and this can, well, should put someone in an ICU for intensive care. And for what it's worth, you can get delirium as a result of having septic shock. So again, there's a lot of interrelatedness of an aging body not being able to compensate for these physiologic stressors, and not all of them are physical. Now, I wanted to spend a moment talking about disability and how it relates to guardianship. We're going to spend a fair amount of time on that in general, but as a means of introduction, physicians and other members of the healthcare team and anyone who's lived through an infection or an illness knows that your body can be impacted in a lot of ways when you get ill or become disabled. If you're on that unfortunate kind of hamster wheel of disability where you go from hospitalization to back home weaker and hospitalization to even further weaker and so on, this can eventually lead to physical disability. But it's important to note that physical disability is not the same as cognitive disability. And moreover, cognitive disability is not necessarily incapacity. Incapacity is a very particular term that we'll explore, but many of you are probably already familiar with. If someone is physically disabled, whether that's due to loss of the ability to use their legs, such as if they have paraplegia or hemiplegia, they like are wheelchair bound, that does not necessitate guardianship, because someone whose body may not be working doesn't mean their mind isn't still working. One such example that a lot of people think of is Christopher Reeves back in the day. He was in an immense amount of physical disability. He required a lot of physical support, but as far as I can remember, cognitively, he was still able to interact with his very interesting high-tech equipment. And there's many cases of this where someone can't use their arms or their legs, but they can still arrange for their needs by asking someone for help or ordering their groceries online, or any number of things, hiring a maid service, setting up their bills on auto pay. There are ways to arrange for your needs to meet your areas of function that are defined by Texas statute, which we'll cover momentarily, that are still possible thanks to modern technology if you're physically disabled. So physical disability, unlike cognitive disability, should not and does not lead to guardianship if it's being assessed appropriately. Cognitive incapacity, however, can, and especially if it's progressive or advanced enough, will lead to guardianship. Sometimes reversibly, sometimes not, and we'll explore that. So because this is a conversation that I could spend a lot of time on and give many presentations on, we're going to narrow the scope of our presentation and time together today to focus on first what normal aging changes are from neurologic, cognitive, and psychiatric domains, and then we'll go on and explore kind of the top two diagnoses or classes of diagnoses in the neurologic, cognitive, and psychiatric domains that can impact an ability, the ability of someone to make decisions for themselves, or again, decision-making capacity. So neurologically, what happens normally when we get older? Well, there are changes in the literal size of our brain. Some shrinking or atrophying of the brain tissue is normal. That just happens. A lot of people's muscles in the rest of their body also get a little bit smaller. Becoming a bit smaller with age is not uncommon. It can cause some cognitive changes, but the brain, even in older adult life, is very plastic, and there's a lot of flexibility in the brain to take on new tasks, learn new ways of doing things. So it doesn't necessarily lead to cognitive impairment, but it can. This would be the area that does lead to cognitive impairment if it were to happen. Changes in how blood flows in the brain is normal. If it's severe enough, it can cause strokes. Because your brain size has shrunk, that's due to a decreased kind of density of neurons, those brain cells, which can again impact learning if it's severe enough, but doesn't necessarily. And additionally, the literal chemicals, the dopamine, the serotonin, the norepinephrine, all the chemicals that help your brain transmit stimulating and inhibitory signals changes. All of these chemicals are involved in learning, but also in mood disorders. That's why many of the medications used to treat mood disorders are things like serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors. Basically, medications designed to stop the already limited amount of neurotransmitters available from being reabsorbed into the brain. They basically keep those chemicals around to improve mood and thinking, anxiety, many things. You may have noticed with yourself or someone you care about that it might take your grandmother or your aging father, for example, a little longer to learn how to use that flashy new phone you bought them, or that, really complicated new remote control. If they're healthy, they'll still eventually be able to learn it, but it might require a little bit more time, a few more repetitions, but learning would still happen because, again, the brain is amazing. When you start losing the ability to learn new information, partly it's due to a pathologic process with neuronal connectivity, how well those neurons are communicating across your brain. And then that was all very central nervous system, but if you move to the rest of the body, changes in these neurons and how they talk to each other, it can become dysfunctional and you can have more pain. Pain is due to the nervous system being disrupted in some way. And sometimes if it happens too often, you can kind of get these chronic pain syndromes. So there's a lot of changes that can happen for better or worse in the normal aging brain. Kind of talking about, our brain in a more abstract sense, we have these psychiatric changes. Of course, unfortunately, one of the harder parts of getting older is watching those you love and those around you often becoming ill and sometimes dying. That happens more as we get older, just due to the normal lifespan and reaching the more terminal ends of it, or in some cases, our friends. We also ourselves experience increased health issues, which can lead to increased frailty due to disease burden. We have more pain potentially, not necessarily again, but sometimes, which impacts our ability to get around and also decreases our health and can lead to disability. Because you go from working during the week to living on a fixed income like Social Security or a retirement pension, your socioeconomic status can shift in older adult, which limits ability to take vacations, to buy, things that you used to buy. And for some people, that can be a challenge to kind of deal with this change in your financial status, especially if you were doing particularly well while you were working. These changes can lead to isolation and loneliness. Loneliness is not the same as being alone. Isolation is not necessarily loneliness. Some people like being alone, enjoy it more than others, and don't feel lonely when they're on their own. Other people can be in a crowded room, but they're not making these important human connections, and they still feel lonely, even when they're surrounded by many others who maybe even care about them. So isolation and loneliness and being alone are all very complicated topics, but they definitely impact psychiatric health, depending on how you and your personality and your situation handles them. As a result, you see more mood disorder crop up as you get older, as well as, unfortunately, more mistreatment, disability, and kind of a literal cognitive or physical inability to escape an abusive, exploitative, or neglectful situation. Those all are risk factors for being mistreated. We have more dependence perhaps on caregivers related and through agencies, and sometimes things go poorly. And then as if that weren't enough, and I know this is very depressing, heart attack and stroke in particular, but other health conditions are associated so strongly with depression in this case, that it is actually best practices following a stroke, for example, to start mood medication, an antidepressant, because recovery has been found to be so much better from a stroke if we can control and manage the associated mood disorder that may be associated with that change in function following a stroke. So it seems kind of silly to start on an antidepressant after a stroke, but there's actually a lot of evidence that it improves outcomes, physical outcomes after a stroke, as well as, of course, the mood. So a lot of psychiatric changes, and a lot of them are very related to kind of your social and your socioeconomic status. And this is just a kind of another circular thing, much like frailty is impacted by hospitalizations and hospitalizations impact frailty. Psychiatric illness also affects function. If you perceive or believe, even erroneously, that you are in poor health, it impacts your function. You might go, what's the point of getting out of bed? I'm just going to die anyway. And then you stay in bed and you get weaker. And then because you stay in bed and you stop seeing people who care about you, your mental health might also take a nosedive. And I say all this, and I want to make it clear, psychiatric illness is not just environmental. There are many, many important genetic considerations in psychiatric illness, and simply exercising more, changing your appetite, or socializing more do not cure psychiatric illness. So I don't want to incidentally imply that psychiatric illness is very, very complicated, but you can have worsening changes in your mental health and your mental outlook associated with changes in, for example, your socialization. So it's part of it, but certainly not the cure. Exercising more, socializing more will not cure underlying psychiatric disease. Medical care, psychiatric care is needed. And I wanted to make a plug here for psychiatric management of depression. In older adults, the symptoms aren't as classic. It's not necessarily just depressed mood. Sometimes we just see changes in appetite, changes in sleep, a new irritability in an otherwise easygoing person. Or maybe they're just tired all the time. We use the geriatric depression scale preferentially to screen older adults because this scale, unlike the ones designed for younger and middle-aged adults, the geriatric depression scale hits on these areas in a better way and is a more sensitive test for identifying depression. Cognitive changes in normal aging. Thankfully, our ability to do things that we previously done before, kind of like life skills, whether that's baking and cooking or changing the oil on our car or, you know, doing our accounting, and our ability to use words, those procedural and semantic memory areas remain really stable. Once you know how to do something, I mean, it's like the expression goes, it's like riding a bike. You can keep doing it and you can get back on the bike and know how to pedal. That remains stable. Our ability to process new information, to learn a new skill, is impacted partly because our attention span changes a bit, especially if we're busy or in a noisy environment or we're trying to do too many things at once. That's something that a lot of people notice. You feel, oh, it's on the tip of my thumb, but I'm too busy replying to that email to remember what it is. So slowing down a little bit and allowing your brain the grace to learn at a slightly lower pace will improve its ability to learn and help you in the process. We also have a little bit more difficulty with working memory. So if I were to rattle off my cell phone number, the younger people in the crowd might be able to quickly retain it, whereas the older adults might get a little bit of the number, but not catch it all because it's harder for them to keep all of that information in their working or kind of circulating memory long enough to find that pen and write it down. New situations, again, are a little bit more challenging because it's new learning. So it takes a little bit to solve, or a little bit more time to solve new problems and to reason your way through it. And that's associated again with this learning changes and executive function, the ability to kind of plan out an action, order the activities that you need to plan out that, and then carry it out. All of those things go into executive function. And that changes a little bit as you get older. It starts to decline more rapidly after age 70, but again, it's not gone, it's not impaired, it's just changes. The good news is that, as you get older, you've had more life experience, which allows you to pull your wisdom, your schemas, your world knowledge, kind of your heuristics, if you will, on how to adapt to novel situations. You can take this prior knowledge and apply it to a new situation and figure out how to respond in this novel situation. The brain doesn't stop being elastic in normal aging. There is a lot of ability for the brain to compensate for this reduced skills by adding more time, taking your time, knowing you need more time and taking it, reducing the pressure, giving yourself, a big breath, giving yourself some grace to go through something at your own pace. Spend a little time researching how to do something before trying something, asking your social supports for help. Like, okay, I know that teenage grandson of mine is really, really good with his cell phone. Maybe he'll sit down and help me with mine for a few minutes. And then practicing. Practice makes perfect at every age. So it's a really good way to, hone a skill that you want. And you can improve all of this by just doing fun activities, whether that's socializing and using those verbal skills, that driving skill to get to wherever you're going. doing brain teasers, doing that Sunday crosswork in pen, not pencil, no, but staying physically active as well keeps those neurotransmitters going. It helps, not the cure, but it helps with mood as well. And really the take home from this first part is that the loss of ability to function, whether you're 95 years old or 65 years old, it's not normal. It is not normal to lose the ability to take care of yourself from a cognitive perspective. So if that's happening, it is inherently pathologic or abnormal and requires some help. So this is where the Texas State Code comes in. What incapacity is again, this inability to arrange for certain areas of function. And what we need as adults to function is, of course, food, but we need to be clothed warmly or coolly enough, depending on the temperature. We need shelter to stay safe. We need to attend to our own physical health and safety by going to doctor's appointments, taking our medications, addressing mental health concerns openly, and of course, arranging for our financial selves, both currently and in the future. So these areas of food, clothing, shelter, health and safety, and finances are what physicians who assess capacity look for. This can be caused by many things, some of them neurologic, some cognitive, some psychiatric, all of which we're going to go through. And these 6 kind of classes of diagnoses are not meant to be an exhaustive list, but what we're going to spend the bulk of this presentation going through, one, so you understand what they are medically, but also the prognosis associated with that and how that relates to ongoing need for guardianship in the future, because some things are transient and some things are permanent. Some things can be treated and managed and kind of bounced back from. Other things can't. And I'll just briefly, since it's kind of been on and off in the news, many people may be familiar with the whole Britney Spears conservatorship battles. From all kind of external appearances, Ms. Britney Spears seemed to have suffered from some psychiatric ailment at some points over a decade ago. Psychiatric concerns often are reversible and can be stabilized with medications, and generally don't, as a rule, require permanent guardianship, which is part of the contention of Ms. Spears's case. So I just give that example to highlight that not every case of incapacity is permanent. If I were to undergo surgery tomorrow, for example, and was under anesthesia, for the time that I am under anesthesia, I am incapacitated. But when I wake up and kind of have cleared the anesthesia from my system, I have resumed, hopefully, the ability, the capacity to make medical decisions for myself. The reason we have an adult present with people having surgery is just in case something goes awry and we need a surrogate decision maker. But in most cases, when people wake up from anesthesia and are kind of back to normal and nice and snappy and quick again, they resume their capacity. So capacity is not necessarily permanent. It can be transient, sometimes longer than others, though. So let's talk about the nature of disability and get to the reason you guys are here. So disability. Disability is a bodily or mental condition that causes some degree of impairment. That impairment can make it difficult to complete the activities you need to do to take care of yourself, as well as other activities, perhaps taking care of another person. It can make it difficult for you to interact with society, your family, to participate in your work or leisure activities, but there's many things that can be impaired depending on the nature and type of your disability. Disability is an unfortunately common problem. 61 million adults, or roughly 1 in 4 adults in the United States have some form of disability. So chances are high that you know someone, especially if you're living here in the South, because for whatever reason, disability is higher in the South. I could make a lot of guesses as to why, but I'll refrain for sake of time. So disability presents in very diverse ways. And again, this is a conversation that I could spend an enormous amount of time on, not least of all due to my own passion, but mostly because of just the wealth of information out there to communicate about this. But Suffice it to say, it comes in, variable presentations that exist on many continuums, both mild and severe, how you came to be disabled. Is it a short-term or a long-term thing? Does the nature of your disability change over time? Like with multiple sclerosis, some people have progressive multiple sclerosis, other people have relapsing remitting. Sometimes in multiple sclerosis, they have better days, weeks, months, and then they'll suffer an attack and be temporarily or permanently disabled from that attack. But the main area of disability that I want to spend time on is body versus mind, because not that the other areas don't impact guardianship and kind of the legal aspects of care for someone with disability, but the body and mind is a big distinction that I care about when I'm determining and assessing for incapacity. So the most common types of disability are shown in front of you, and I've circled the ones that have to do with basically kind of cognitive concerns. Certainly hearing and vision and mobility are important disabilities, but I care a lot as a geriatrician doing mistreatment work about cognitive disabilities that impact your ability to self-care and our independent living. And if I had made this kind of bar graph, I probably would have lumped all three of those together, because for me, a lot of the times, especially patients and clients that I see, when there's sufficient cognitive disability, it impacts your ability to live independently and take care of yourself. So in many ways, these can be indistinguishable for someone doing what I do for a living. So again, just a smidge over 1 in 4 older or adults, not older adults, 18 and up, has some form of disability in Texas. And again, when you're comparing Texas versus the United States, you are seeing these slightly higher rates, again, very, very small, like half a percentage point. But still, when you're talking on the scale of millions of people impacted, half a percentage point is quite more than a handful of additional people impacted. So it is significant, not least of all because these are humans, people who want to be able to do things like all the rest of us who don't suffer from disability. So it's important on a person to person, but also, a legislative and healthcare perspective. So one of the problems with disability is the stigma attached to it. When you think of bodily disability, you think of things like someone who has suffered an amputation for some reason, or maybe they have a congenital limb difference, which is kind of the medical and politically correct term for being born without part of an extremity. They might have gait dysfunction, they might suffer from chronic pain, they might be blind, they might have hearing loss or be completely deaf, they may have burns or some genetic disorder, or any number of things. But these are visible disabilities. More often than not, you can see, unless they have an amazing prosthetic and are very good at compensating for it in the case of amputation, you can often tell that someone has a physical disability. In addition to the tools we use, whether that's canes or walkers or vision sticks or hearing aids or pacemakers, a wide range dentures of things exist that kind of alert the public that there might be a physical disability present. And that makes it more socially acceptable. It's not hidden in the shadows. It's not secretive. It's something we can see, and for better or worse, where we and of course the person with the disability are confronted with on a regular basis. And because of that, there's a lot of more representation in the media, and importantly, positive representation in the media. They're people who, get back to their sports, they get these amazing features in like local and state news about how they're a hero or they're handy capable, emphasizing their ability, not their disability, or they're differently able. They're still able, they're just differently able. They're brave, they're inspiring. And again, as I mentioned, there's all these options and tools and technology that exists to help them. Even again, Christopher Reeves had this elaborate, very technologically advanced wheelchair with like a straw that he could blow into to interact with his environment. I had a patient with another disorder who literally was almost essentially completely paralyzed due to a progressive illness, but he had a machine where he could use his eye movements to pick different letters on the screen and commonly used words to spell out and communicate with me just by eye movements. It was that sensitive that it detected like his pupillary movements. Blew my mind. It was the coolest thing I ever saw. And we invest resources into things like this. And because there's so much support and because it doesn't necessarily affect cognition, this doesn't really lead to cognitive incapacity and guardianship cases more often than not. But disability of the mind is another story. It is more likely to lead to incapacity and guardianship because it's not something we can see. Sure, I mean, if you're located in Houston or anywhere with kind of a downtown area, a lot of us have seen people, homeless people in downtown, for example, who seem to be talking to themselves or are poorly groomed or malodorous, or who just, for lack of a better word, give off the stigma, the stereotype of being homeless or disabled. And it's weird, or they're, the R word, the not socially acceptable word, retarded anymore. We're not supposed to use that appropriately because it's very much insulting, but also carries heavy stigma, especially historically. But they're made to feel worthless and useless, like they can't contribute because they have mental illness or dementia. And that's not necessarily a fair assessment ever, but especially when these people are in situations where they still fully understand what's going on. It's very stigmatizing, very disheartening. And we don't have the same assistive devices to compensate for these cognitive disabilities, disabilities of the mind, that we do for the more bodily ones, which really just further worsens this negative representation. So it's a very, very challenging situation when you have a disability of the mind, especially in like, for example, cases of dementia, where you still have, enough cognition, enough awareness to know that people are, whispering behind their hands, behind your back. So besides, of course, being compassionate and kind, recognizing that, again, disability does not always mean incapacity, and certainly does not make them, have a reduced IQ or otherwise unintelligent or unaware. They're people with feelings. So little plug there, but also just talking about how hard it is to be in these people's shoes, especially early on. And because they can't always communicate with us later, we don't really know how much they're impacted by harmful comments later on. But I believe they probably still have an understanding of someone not caring for them well. So let's talk about the main types of disability that can lead to cognitive incapacity and when appropriate, guardianship. So we'll spend some time talking about neurologic ailments like stroke and traumatic brain injury. We'll then move on to cognitive disabilities like dementia and intellectual and developmental disabilities, or IDD. And we'll end this area by talking about two of the most severe psychiatric illnesses. Again, some people function very, very well with these, so it's not meant to say that every case of schizophrenia or bipolar disorder is like that. In fact, most aren't like what I'm going to describe, but again, I'm focusing on the ones that go to the point of incapacity and needing guardianship. And as you guys know, guardianship is kind of like the last train in the station. It is a very restrictive measure designed to help protect an adult, but it's still the loss of, kind of the age-given rights that you get when you turn 18, when you become an adult. So it's a big step. It's a big deal to take those rights away. And depending on the cause, as we'll learn, something that should be reconsidered not infrequently, to see if someone is in fact still totally incapacitated and in need of a guardianship, or if less restrictive measures are an option. So what is a Well, unfortunately, a lot of us may have experienced this in a loved one, and hopefully not yourselves or a loved one, but in case it's happened, a stroke happens essentially due to when a blood vessel, an area of the blood vessel supplying blood to the brain and oxygen, nutrients to the brain, becomes blocked in one manner or another. This can happen with a couple different ways. One is embolism. Embolism is a traveling blood clot. This can happen when a blood clot forms due to a condition called atrial fibrillation, where your heart has an irregular rhythm and blood sometimes pools and clots while it's stagnant in the heart, and then can travel up to the brain and block a small vessel. Depending on the size of the clot, depends on where the blockage can occur. If it's very small, it'll clot a very, very terminal branch, a very tiny branch of the blood vessels in the brain. But if it's larger, it can block off a larger part of the artery. So size matters. Alternatively, you can get a stroke when a localized area gets clotted off, becomes extremely narrow due to basically damage to the cellular wall. Cholesterol can fragment a wall of a vessel as it floats by, which is why controlling cholesterol is important. You don't want these little hard chunks of cholesterol building up or breaking off and slamming into the walls due to turbulent blood flow, because if it hits the side of the vessel wall, platelets will rush in, just like when you get a scab on your skin, platelets rush in to make a scab to protect that blood leaking out. But the platelets accumulate and make a scab inside of an already very small vessel, and then you get progressive narrowing and less blood gets through, and it can result in a stroke because the vessel eventually becomes so sufficiently blocked that not enough or no blood gets through. So again, you can have a traveling clot or a gradual narrowing called a thrombosis. About 20% of cases happen when a vessel bursts open, like an aneurysm you may have heard, and blood spills out onto the brain tissue itself, which, blood is very good when it's hanging out inside the vessels. It's not so good when it's on the brain tissue itself because of all the many chemicals and electrolytes and things in there. It's actually kind of caustic to the surface of the brain. So a lot of ways a stroke can happen. And depending on where in the brain is affected by ultimately that lack of blood flow or the burst and a lot of blood where it shouldn't be, you can have the classic symptoms where like a limb goes numb or weak or tingles. You can have the classic facial droop. You can have the slurred speech. So, those are the things that people commonly think of. But also you can have changes, a sudden onset of dizziness, instability, difficulty walking. You're kind of like bumping into walls. Seems like the world is spinning around you, a vertiginous or vertigo kind of syndrome. You suddenly lose the ability to see out of one eye. If you have a severe headache that just seems to come out of nowhere and does not go away, or if you just become confused, again, that delirium, that brain attack. All of those can be signs of a symptom. And of course, all of these, PSA from the doctor, go to the emergency department don't wait and see if it gets better. Worst case, you're there to have a doctor reassure you. We are always happy to reassure people if it prevents a bad outcome. So we don't want you waiting at home with these things. So how do people do after this? Well, of course, it depends on how quickly you get to the doctor's office. But if you get, or not the doctor's office, the emergency room, very clear, emergency department needed. But if you get there fast and they're able to alleviate the block through a lot of medical technology, you may make a full recovery. There may be no injury longstanding to the tissue of your brain. We say time is tissue. So the faster you get medical attention, the more likely the tissue, your brain, is to recover from the hopefully very temporary insult. Unfortunately, people don't always make it in time, or they choose not to go, or they don't understand that the symptom they're having is a stroke, or because of incapacity, they don't understand the nature of the illness they're experiencing. So sometimes you can wind up permanently disabled. Sometimes that's a physical disability, and I think we see that a lot, but again, that's because there's a lot of media representation of that. But what we don't see as often is the development of a type of dementia called vascular dementia, which is brain-related changes, cognitive changes due to strokes, generally more than one. So these are unfortunately people with like a lot of strokes. Some strokes can be very small and not cause really obvious symptoms, but eventually enough stroke damage accumulates and you have cognitive changes consistent with a dementia picture. These factors are most associated with the development of a vascular dementia. And you can see there's a lot, if you're confused or have seizures following a stroke, if you have lots and lots of strokes, if immediately post-stroke, even after treatment, you're having difficulty with language, if the stroke occurs on the left side of your brain. This is because most people are quote unquote left brain dominant because most of us are right-handed. It's kind of opposite. There's a lot of association there with like less ability to compensate for it because we are more, most of us right-handed folks are more dependent. A lot of our abilities come from the right side of our brain. That's not to say the left side can't transfer its abilities to the right side and you can't relearn new tricks, but it poses some difficulties. But lots of factors are associated with developing vascular dementia following a stroke. It doesn't always happen, but it can. But when it happens, it's irreversible. Vascular dementia is a sign that there is permanent damage, permanent disability resulting from that stroke and the associated, big word, cerebrovascular disease, or basically the disease that led to the stroke in the first place is still present in the brain. And we get this more in the, or rather, let me say, this type of dementia does not exist necessarily on its own. It's one of the few dementias that we see with things like Alzheimer's, because Alzheimer's is coming from a very different genetic origin than vascular. Vascular is kind of a full body, you know, if you're at risk for a stroke, you're at risk for a heart attack because that same process is affecting vessels all over your body. And that's separate from other sorts of dementia. So vascular dementia, unfortunately, likes to piggyback with other dementias if present. So if you get a case for someone who has a history of vascular dementia and they're under your care as a guardian, or you're, you know, the attorney kind of managing some of this guardianship, what can you expect? Well, I wouldn't recommend guardianship early on. A lot of recovery, if it's going to happen, is going to happen in generally the first 3 to 6 months with adequate physical therapy, these early interventions. And you might continue to make some recovery up to about 18 months out. And these are just round numbers, but just to give you some ballpark. But if sufficient recovery isn't happening after around the first year, and someone is showing a lot of ongoing cognitive problems, despite doing all the appropriate therapies, speech therapy, physical therapy, occupational therapy, that sort of thing, that's when guardianship might start becoming more appropriate again, all other things being equal, suggesting incapacity. Unfortunately, up to about 1/3 of people at 6 months are still showing significant cognitive disability. And again, that's kind of when you're going to get the bulk of your recoveries at 6 months. So if you have someone at 6 months showing disability from a cognitive perspective, that's, you know, you're gonna, because guardianship can take, you know, many months in the state of Texas, like 6 months, it might not be unreasonable to have capacity assessed at that time, at least preliminarily. And it can always be reassessed if further recovery is made. You know, again, guardianship does not have to be a permanent thing, but we don't want someone falling into a state of self or medical neglect while you're trying to reach, you know, that 18 months to really see what it is. Again, most recovery is going to happen earlier on. And we see a lot of depression, as I alluded to. That's why it is, you know, gold standard to prescribe antidepressants of a specific class following a stroke, because depression impacts recovery, as well as cognitive function, of course. But then, you know, if you can't talk, it's really hard to hang out with your friends. If you used to play golf and you can't walk anymore, it's really hard to play golf. You know, and unfortunately, all of this results in about a quarter of people being placed in institutions. So it can be pretty bad if vascular dementia is the outcome. So as I alluded to, you know, the goal is to reduce these risk factors. Something happened that made your blood vessels narrowed, whether that's a heart condition throwing clots, you want to manage that heart condition, whether it's an overall high cholesterol and platelet dysfunction, you know, a lot of fancy medical terms for your vascular system isn't so great. There are medications that we can use, not least of all baby aspirin, to kind of prevent future strokes and thus slow a further cognitive decline. So most important following a stroke, if your client has a stroke, you want them to do all the recommended therapy. And if they're not being prescribed physical occupational speech therapy, if you are acting as their guardian, you want to make sure that this is something that at that post-hospital discharge, you want to make sure that they're getting it, because again, most recovery is going to happen real fast, and it's not what the person who had the stroke wants to do, but it's what they need to do to have maximal improvement. But then, because there is so much physical disability as well associated with stroke, and physical disability that's not managed can lead to isolation and reduced cognitive function, you want to make sure that they have their mobility aids so they can keep seeing people, keep socializing, keep flexing those cognitive muscles to maximize their brain function. But you want to keep them safe while you're doing it. So making sure their homes are outfitted with, you know, mobility aids, shower chairs, grab bars, something so they don't slip in the shower. Again, you don't want to add insult to injury. So making sure they do their rehab and have what they need in their homes, and, you know, for some people in their car. But again, if it's setting to the point of vascular dementia, you know, you're thinking a little bit differently. And it might be, if they have dementia, you want them socializing. You manage that depression in multimodal ways with medication, but also improving their socialization, whether that's in a day program or a senior center if they're more, you know, capable. But also, you know, keeping them engaged even if they're at home by having them do activities, having friends and family visit. There's programs, one of which that I have no affiliation with, but just that comes to mind is Visiting Angels. There are volunteer organizations that will visit seniors in their homes. There's community support groups as well, so they can realize that they're not alone in this new unfortunate disability. And again, you want to reduce the risk of a future stroke, because every further insult to their brain is just that, it's a further insult to their brain, and it's going to impact their cognition. And the doctors that you want to have involved ideally are neurology and geriatric medicine. Neurology, they're the brain experts, and geriatric medicine, we are also brain experts, but in kind of a different way. And we manage things very holistically and care about, you know, their function, their socialization, their family involvement. We want to look at the whole adult. They're not just a brain to us, they're a whole person. So another neurologic concern is traumatic brain injury. Now, traumatic brain injury sounds very dramatic, and at the worst cases, it is as dramatic and devastating as it seems. But traumatic brain injury comes on a wide kind of range of activities. So what a traumatic brain injury is when there is an alteration to the brain's ability to function, or finding of a new pathology in the brain due to an external force. There's many ways that can happen. It can be because something literally hits you on the head, intentionally or not, if there's a mistreatment, or maybe just you're reaching from something from a high shelf and it fell on your head, or you're playing sports and you got kind of gonked on the side of the head. Certainly being in a car accident or any other accident where there is a rapid change in your acceleration, where you decelerate and your brain keeps moving in your skull and your seatbelt holds you forward and you whiplash forward and then back. We also call that by a lovely fancy French name called contre-coup, front and back injury of the brain. The brain hits the front of your skull, then slams back into the back, and you get an injury in the front and back. You literally see stars. You see part of your vision center is in the back of your brain. That's why you see stars, because your brain just smacked against your hard skull. That's not good, obviously. It also is not great for your neck and your shoulders. Or if you're, a military vet, you might have encountered blast forces, or if you just played too dangerously on, July 4th, Independence Day with some fireworks. Lot of causes for damage to the brain. Again, it comes in this wide range. Something as simple as a concussion, you headed the ball too hard in soccer practice, and yeah, you can get a mild concussion. That, many of us watch football or the Super Bowl, and you see those impacts. And while those helmets are good and better than nothing at reducing force by kind of diffusing it across the external skull, the helmet, it diffuses the force across the whole skull. It does not stop that there was still an impact. So it's not perfect, and you still see people concussed on the field in sports, especially where they don't wear helmets. But most concussions are reversible, and you get over the sequela eventually. But then the severe end of that is, these people in the vegetative states, like the Terry Shivos of, and many, many people like her, and certainly a lot of contentious legal battles in that case. But you can see the range there. And as you would expect, especially when you're on the severe end of the spectrum, this is incredibly expensive, not just because so many people are impacted. Again, most of these are concussions. Most of these are reversible concussions that they might suffer a few weeks, maybe a few months of lingering effect if they're unlucky, but most of it's reversible. But there's still the really sad cases as well, and it's horrifically expensive, the amount of long-term care, the amount of ICU care following a severe injury. An unfortunate amount of our organ donation results from people who are brain dead but cardiovascularly, their heart still works. They are cardiovascularly alive, but their brain has ceased to function. They are functionally deceased. A lot of organ donation comes from that. And that's a plug for organ donation in general. Please sign up to be an organ donor if you wish. But we see so much traumatic brain injury, and it's so expensive to care from. And unfortunately, over 50,000 people die from these severe traumatic brain injuries. But they're not even the expensive parts, because again, if you need long-term care for the rest of your natural life, that's incredibly expensive. It's thousands of dollars each month to live in long-term care, not including medical bills. So not including caregiver costs of family members who may have to quit their jobs to be a long-term caregiver. There are far-reaching economic impacts to this. So wear your helmet, buckle up, and do all the smart things that your mom and your dad and your doctor told you to do. But some of it is accidental. Most of it is accidental. And falls are at both kind of ends of the life spectrum. You get this kind of bimodal distribution of fall as the mechanism for traumatic brain injury. And then in kind of some of the in-between years, things like sports, unfortunately violence, mistreatment, and even self-perpetuated violence contribute a lot. Now, what's interesting is we classically think of, like car accidents as the main cause of this, but actually car accidents as the cause of traumatic brain injury, especially devastating traumatic brain injury, are falling, which is great. Cars are getting safer. Technology of seatbelts and crumple effect and cars is improving. So some good news there, but it's still a big problem in our society. So how do we know how that traumatic brain injury is going to turn out? Well, a lot of it depends on how severe the traumatic brain injury was initially, and how old we were as well. Again, as you get older, the size of your literal brain shrinks a little bit, which means there's more space between the outer skull and your brain. When you're young, your brain is really packed into that skull. A lot of people probably seen these babies with these big old heads because there's a lot of brain in there. But as the brain in the skull grows and eventually stabilizes, the sides of the brain stays stable for a while, but gradually you get a little bit of atrophy, and that extra room for the brain to kind of move in the skull and the cerebrospinal fluid increases the risk of injury, because there is literally more space for your brain to kind of slosh around and hit the walls of your skull, which increases the risk of injury. from a mechanism like a fall that might not hurt a younger adult as much. So if it was a mild traumatic brain injury, overall, it's a good prognosis. You still want to see a neurologist, you still want to see the doctor, but a lot of it is resting and giving your brain the time to recover. It was injured. If you would rest your knee after twisting, your knee or twisting your ankle, you want to do the same for your brain. You want to avoid a secondary impact. That's why they pull football players out of the game. That's why they pull any sports player out of the game, or should, when there's a head injury, because a second impact, even if it's mild, can be fatal. A second impact can be devastating, even if it is as mild as the first. It's that repeated injury. So, if you have a client with a head injury, don't let them go back to playing sports at their group home. Tell them to sit it out for a while. And even if you do everything right, unfortunately, there can be ongoing disability. So some of this is kind of a post-concussion syndrome with personality changes, mood disorder, concentration, difficulty paying attention, but it can also impact your sleep. It can cause seizures if it's severe enough. And again, all of this should require immediate medical attention. But the classic punch drunk that we see in boxers and sometimes even football players in particular, every subsequent trauma, repeated head trauma, even if it's spaced out, even if it's not that immediate injury, increases the likelihood that you're going to have encephalopathy, basically brain damage from trauma. So if it hit in the head once, you really want to be careful, indefinitely, and make some modifications and recommendations to your wards. And to some extent, the ones with the mild injury, we got to really stay on them, because they're the ones who are getting back out there and resuming life, sometimes like nothing's going on. The people, unfortunately, with more moderate or severe injury, these are the people that are more disabled, who aren't necessarily going to be resuming their normal activities, who you're going to be seeing as the more permanent guardian cases. This is especially true that neurologic function and lasting neurologic dysfunction is likely to occur, especially if there was additional harm to the brain following an injury. So if you have a ward who was in a severe car accident and then went into cardiac arrest, where their heart stopped and they stopped breathing, and so the brain also lost oxygen, lost blood flow briefly, even if they come back to life, there was kind of a double injury there from the initial physical impact to the brain, but also subsequent kind of vascular oxygen deprivation. So how much of America is affected by this? Well, alarmingly, it's 1 to 2% suffer long-term disability. And again, these are the kind of cases that we on this presentation might be seeing. They have increased rates of mortality. It impacts their longevity. And some of them remain in a vegetative, non-communicative, non-interactive state for the rest of their life. Some will wake up, but they don't wake up like in the movies. They don't wake up totally fine, ready to resume their life. Like, they are severely disabled from physical and cognitive standpoints, almost always. It is very rarely that you get the, the so-called miracle cases. It's hard. And again, maybe a third, maybe 2/3 regain some independence over months, but it's not like in the movies at all. It's arduous work with many setbacks, physical and cognitive, and a lot of psychiatric consequences as well. So how do we help them? How do we support them? Well, again, we maximize their function early in the recovery as much as we can. We get them in all those therapies, including cognitive therapies, which is kind of a new area of rehabilitation. We make sure that they're not severely depressed. We make sure that other things aren't impacting their function. Then we push them a little bit. We push them. We say, look, you got to stretch yourself if you're going to get better. You can't expect to do the exact same thing, the same effort, and expect to improve. We all learn new things by stretching ourselves, and recognizing and encouraging them, saying it's okay if you mess up, it's okay if you fail, it's not the end, this is just a step in learning something. And when you have these failures, it provides insight and self-awareness, so you know where to help your wards improve. So it's really an opportunity, but they have to feel supported to, keep trying. So you do that by encouraging them to participate in their prior activities, even if it's watching from the sidelines for a little bit. Get back involved, be in a day program, be in, again, these support groups, interact with people that they, that build them up, that celebrate their successes and their goals. And you want to have neurology on board. This is big. I mean, geriatrics is always happy to be involved if it's an older adult, but neurology, since this is a physical brain injury, that's who you really want, because you want to make every effort to avoid repeat injury, and having a neurologist on board to kind of guide that is going to be key, who you want. So a topic as a geriatrician that I am especially interested in is dementia. Dementia affects 50 million people. And unfortunately, that's only going to get worse as our population pyramid, so to speak, shifts to an increasing amount of older adults. So what is dementia? Well, dementia is a brain disorder that causes a host of symptoms, not only memory loss, but in order to diagnose dementia, you need changes in your function, your ability to make decisions for yourself. A lot of overlap eventually with capacity here, but it affects how you interact with your world, how you communicate with those around you, and even kind of like the self-talk that you have, your thinking, your decision-making, your reasoning. Again, it's not just leaving keys in, the refrigerator. It's a lot, or getting lost on the way home. That's part of it, but we really, really care about function when we're diagnosing dementia. If there's no impairment in function, when I'm diagnosing dementia, without impairment in function, it's not dementia. You need more than memory loss. Dementia is kind of an umbrella term. It refers to numerous causes of dementia, whether that is dementia due to alcoholism or a stroke or the classic Alzheimer's, or damage to the frontal and temporal lobes, frontotemporal dementia. Again, dementia is kind of a catch-all term, and it's not really clear, and that's why we have people like geriatricians and neurologists involved when these diagnoses are at play, so we can really delineate what type of dementia is going on, and thus the expected prognosis, progression, and treatment if warranted. It's not the same as delirium. Someone being acutely confused due to an illness or an injury. Delirium resolves gradually. Dementia is almost always a progressive and irreversible condition, which is very important when it comes to guardianship. Again, it's not just forgetfulness, but it's not always synonymous with incapacity early on. Eventually, all dementia leads to incapacity. It is, again, progressive, but sometimes you get it in younger adults than you would expect. And so I don't really care if you're 65 or 55. If you've got a geriatric problem, send them to geriatrics. We don't have an age cutoff. And even though it is prevalent, even though, again, 50 million people are impacted by it, it is not a normal part of aging to lose the ability to take care of yourself and to become forgetful enough, rising to a consideration of and an assessment of dementia. And here, again, this is just, I'm not going to read this to all of you adult learners, but this is not even an exhaustive list of the types of dementias that physicians deal with. And you can see parenthetically, there are kind of some information about it. But what I'll point out is that Alzheimer's is by far the most common type of dementia that we see. But and probably second would be vascular. But if someone is having changes in like their personality and kind of seems inappropriate or is having new language difficulties, you're probably going to be looking at a frontotemporal picture. If they have a known history of Parkinson's disease or Huntington's disease, you'll eventually see some cognitive changes, but it's not often the presenting feature. If There's a lot of psychiatric kind of like hallucination features. You might have a Lewy body if they have known substance abuse issues or exposures, depending on what they are. You could have some of the following categories, depending on what that exposure or substance or disease is. And as I alluded to, delirium is not dementia. They're different. Delirium is a risk factor for dementia, and dementia is a risk factor for delirium. If you have dementia, you are more likely to get delirium in the hospital, and if you have delirium, you are more likely to have long-lasting dementia like cognitive changes following delirium. So delirium is something very important. It's not simple. It is an emergency. And, you know, all of these things are kind of the diagnostic criteria we use to differentiate. But unlike dementia, which comes on gradually and slowly, delirium is a sudden onset. Sometimes they're more lucid than other times. And it's associated with some underlying cause, generally, which is reversible. And when you reverse that underlying cause, when you treat that UTI or discharge them from the hospital and get them back in their home setting or manage their pain, whatever it is, this confusion, this distraction, this lethargy or agitation, this illogical, you know, thought processes, all of these that were previously reduced will start to resolve. And then weeks later, if there's still underlying cognitive problems, that's when they're going to want to see someone for an evaluation for dementia, but not while they're in the thick of recovering from some situation. So this, I hope, is a helpful slide that I will not read every word of, but meant to highlight kind of the differences between what is normal aging based on what we saw very early in the presentation versus what we've seen dementia to be. And it's okay to forget things. It's okay to make little mistakes, occasionally get turned around or miss a turn while driving, or maybe forget a birthday, or just kind of maybe not feel like socializing once or twice. But all of these are more normal, but when it starts being a problem, when it starts being severe, when things are missed and forgotten completely, not on the tip of your tongue, they don't come back once they're gone because they were never made as a memory to recall. When there's huge personality changes, mood changes, when they become just not the person that you know, that's what dementia looks like. It is not a mild condition. It's being severely off, severely wrong, winding up in a different city, not a different part of your neighborhood. It's much bigger, much more concerning. So there's a huge gulf between what normal aging is and maybe some small deficits you see in there, and then what rises to the level of dementia to a diagnosing physician. But you can always bring your family members in to be evaluated. We're happy to put minds at ease and reassure. And sometimes it's just too early to tell. Sometimes things take a little while to kind of fully manifest, unfortunately, but we're here to support you, your wards, and your personal family members as needed. So dementia, as I've said a couple times now, it is permanent, it is progressive, and save a rare corner case, it is irreversible. It will ultimately lead to incapacity that is irreversible. This is not a guardianship case that's going to be changed unless some other contributing factor, a dementia mimic, like a depression or severe thyroid or electrolyte or vitamin imbalance, was missed on the initial assessment. Vast majority of times these are not going to have restitution of capacity. And dementia, one way or another, always leads to death. You basically don't die of dementia, you die of some consequence related to dementia, which is outside the scope of this presentation. It's a presentation in and of itself, but most of the time it results in institutionalization or total care at home. And yeah, it's irreversible. This is a permanent guardianship. So you and your ward are till death do you part on this case. So the best way to manage dementia is to kind of maximize their independence while you still can. You want to get them involved in any therapies they need and that their doctor thinks are important. Make sure that they're not, severely depressed about their new dementia diagnosis. Make sure the rest of their health is as good as possible, but also keeping them engaged. Again, engagement is so important. You don't want these people to quite literally rot away at home. Like they, early on in dementia, they still have cravings and interest for, you know, everything that they love, and they're still capable of so, so much. And they still have interest in that. So involving them sometimes, you know, pulling the horse to water a little bit, but get them involved, encourage them to be involved with those that they care about, in situations where they can safely help other people, maybe like supervised volunteer activities, anything to keep them going and focused on their abilities rather than their disabilities. And geriatricians and or neurologists, depending on your community resources, are instrumental. But again, neurology focuses a lot on the physical manifestations of dementia. With no insult meant, geriatrics often is more comprehensive in kind of all the aspects. And we are not unfamiliar with incapacity determinations and guardianship either. IDD, intellectual and developmental disabilities, is something that as a geriatrician, I don't encounter a lot. This is more the younger adult crowd, but it was an important thing to consider. It is another umbrella term that classically includes, you know, kind of salient things like autism spectrum disorders, congenital disorders like someone who was born with fetal alcohol syndrome or Down syndrome or another trisomy or genetic disorder. But there's so many things that can contribute to having an intellectual or developmental disorder. And there's a wide range of function and ability as well as disability. So the prognosis really depends on this underlying cause. And physicians, social workers, other healthcare counselor team members are really going to be instrumental in this. And so some people with an IDD diagnosis are extremely functional, independent, do, you know, all the quote unquote normal things of life, whether that's becoming married or having a partner or having children. Many of these things are accessible and reasonable, and they never cross our paths because they are so good. Whereas others are much more dependent, even with vocational and life skills training, and they do become wards in order to prevent severe neglect. And so the ones in the middle range who might still wind up requiring a guardian, those are the ones who there's a lot of opportunity for improvement. They tend to be institutionalized less, and they're more likely to be community dwelling, even if that's in like a personal care home and group style living. They're the ones with better prognoses that might cross our paths and might present an interesting opportunity for us to help them grow and become more independent. So since I was already touching on it, I want to mention the importance of a specialty of medicine called medicine pediatrics. These are doctors that are trained in both pediatric and adult medicine through a long training program, and they are the experts in bridging conditions that start in childhood and span into adult life more and more. Because of increased medical care, we see these adults living longer. That used to be a childhood problem, but now we have this field of medicine that's medicine and pediatrics to kind of bridge that gap, because those of us like myself with just adult training have far less knowledge on the IDD folks, because I just simply wasn't trained in child medicine extensively as they were. So they are great people to look up, but a really good surrogate for that available in most communities is family medicine, because they also take care of you from kind of from cradle to grave, as they may say. So you want to have those type of physicians, someone who's skilled on the entire lifespan, but also specialty specific, depending on the underlying cause. You might need a neurologist or a psychiatrist, or maybe a developmental pediatrician or psychologist. And keeping them involved with their medical care is important, because some of these conditions, like Down syndrome, for example, carry higher risk for medical conditions, whether that's a cardiac condition or a cognitive condition. There are associations based on the underlying cause of these conditions that may require additional medical support, even more so than some of the other disabilities that we are discussing. But making sure they have what they need by keeping them hooked in with their medical team, and it does take a team, it takes a real village, and you guys are no small part of that, to have what they need to maximize their function is key. They also thrive, since many of them, with no disrespect meant, many of them are childlike in their intellect. They thrive on routine and consistency, just like developmentally typical children do. Routine is really important, but being cautious and preparing them for things that might be disruptive to their routine, preparing them in advance, again, like we might do for a developmentally typical child, is really helpful. But when we can, just avoiding the disruption, and making sure, because of the risk for mistreatment and mental illness and associated medical conditions, we want to be really vigilant about the factors that are affecting them. And again, yeah, unfortunately, parents die, and many of these people are very dependent on their parents. And that's how, when the parents die, they become wards. That's often when the transition happens. You guys, as guardians and attorneys and other wonderful professions, are, at that juncture. And so a lot of support is needed. And keeping in mind that they might not need as restrictive a placement as other people, because again, you want to maximize their independence. And you do that, again, very similar. A lot of these slides are similar because engagement in day hab programs, vocational training, leaning heavily on your healthcare and case management teams, friends and family that are available to kind of maintain some normalcy, even if mom and dad are deceased, it's still important. And again, this focus on ability, these people in particular can be very, very capable, surprisingly so sometimes, and focusing on that and growing them and stretching them in all the right ways, rather than being down on the limitations and disabilities they may have. It matters a lot to them. So the last two conditions that I'm going to spend some time on before offering some strategies on maximizing independence and kind of tips to, I don't want to put you guardians out of a job, nor the guardianship attorneys that may be on, but we want people to live to the extent of their function. And so we'll spend some time on that. But before that, I want to spend a little time talking about schizophrenia and bipolar disorder. Psychiatric illnesses in general are on the more reversible side of this spectrum. So schizophrenia is probably one of the most severe psychiatric illnesses that humans can be diagnosed with, because it is characterized by almost a disconnect from reality in the severe cases. And again, there is a wide range of what schizophrenia can present as and how much it can impact your day-to-day function or how well you do on medications. There's some individual difference there, but schizophrenia is characterized by chronic or recurrent episodes of psychosis where they're delusional or hallucinating, and it impacts their ability to function because they simply are operating in almost alternate reality from us. And diagnostically, we see these symptoms that either detract from their personality or add something to their personality. And what I mean by that is like a positive additive, not positive because it's a joyous thing, but positive additive symptom might be the new presence of hallucinations or delusions or paranoia and suspicion, or they may become disorganized. It's something is added to their baseline personality. Whereas a negative or deficit symptom is that when they lose ability to pay attention, to remember, to have executive control over their activities, they lose speech, they become catatonic, not interactive. So that's kind of the difference. And you get a mix of positive and negative symptoms in a lot of people. And historically, medically speaking, positive additive symptoms are much better controlled and managed and have a much more positive prognosis with medication because they are manageable with medication, whereas the negative deficit symptoms are much, much harder to overcome. So just something to keep in mind, that hallucinations, even though they are dramatic, or the delusion that there's someone living in their, basement or their attic, those seem very dramatic and they're up in our face because that's what we see classically as schizophrenia. You think the movie Beautiful Mind, they don't talk about all the negative symptoms, the ones that make them withdraw into themselves and disengage from society and jobs and income and self-care, cleaning, those aren't the ones we talk about, but those are the ones that really do the damage. Everything else can be pretty well managed, oftentimes by medication. But even so, in the worst cases, it can be very disabling and hard to manage. And because of that, there's huge caregiving and societal costs. And unfortunately, us more, psychiatrically healthy people unfortunately contribute to that stigma. And that results in suicide. It results in dysfunction because there is, again, as I alluded to earlier, that person in downtown that you're not sure if they have a Bluetooth in or they're talking to themselves. We instinctively, as humans, shy away from that. That's a little scary. They're erratic. We don't know what they're doing. I myself, as a young woman, I remember when I was in college down at University of Houston for a while, I would cross the street to the other side just because I was like, I don't want to get in trouble. I don't want something unexpected happening. And it's not that that's bad necessarily, but it contributes to the stigma. And so it's a hard line to walk. But suicide is a real risk with mental illness in general, but in the severe ones, 5% of people with schizophrenia die by suicide, and 10% of all people who die by suicide have schizophrenia. So it's a really prevalent problem. I thought these illustrations by artist Sean Cross, which you can find at the link below, he illustrate, or she, I actually knew a woman named Sean. So he or she illustrated what mental illness might look like, what it might feel like. And I just thought these were just so profound that I wanted to include them. So very, very kind of beautifully frightening images. So prognosis, what does it look like? Well, the prognosis is variable depending on what type of symptoms you're having, when the symptoms start, how gradually they come on, how intense they are. The best outcomes happen, again, with these positive symptoms, if the symptoms are intermittent, if they're well controlled, and if they come on abruptly, which seems counterintuitive. Because if something creeps on slowly and the symptoms really don't abate, and again, it's these negative or deficit symptoms, those are what you get the poor outcome, because again, they're withdrawn from society. They're not necessarily getting that same support. And so even in cases where things are really well controlled by medication and they might come out of guardianship or they might never even cross our paths, life stressors still can have really significantly harmful impact on complicating treatment courses and medication adherence. So again, much like with the IDD, it's important to even just role play and prepare for situations that might be coming down the line. Like if a loved one is sick, talking through that and having safeguards in place early on, and using these multidisciplinary teams. Again, no one expects anyone here to do it alone. Because there are wide-reaching impacts of these diseases, you really want to, address how to reduce the symptom burden, remain adherent to treatment, whether that's medication, support groups, provider services, using long-acting formulations of medications like Haldol shots you can receive once monthly to reduce that burden, to reduce the likelihood that one morning they're going to wake up and say, I'm fine without my medications, and then they lapse back into psychosis. If they have a long-acting formulation on board, they're less likely to have that happen and more likely to take their medications if they are in their so-called right mind. Again, creating these safety nets is important by preparing them for things that can be triggering. And knowing kind of what their triggers are, having that relationship with your ward is important. And having it be a trusting one as well. But taking appropriate safety measures too, like you don't want a weapon in the house in case there is a psychotic episode. Providing extra support when you need to, opportunities to meet basic needs, and then just emergency backup plans like you would with anyone. But being positive, being a trusted confidant is important. So you are there to celebrate their strengths and successes successes and their function and their role in community. Who they are is important. Just because their world is a little bit different doesn't mean they don't contribute something. Again, I don't know if that artist has schizophrenia or some mental illness, but I mean, that's some amazing art. He clearly, if he does have mental illness, is, you know, communicating something, has a role in society. And of course, as you would guess, you want a psychiatrist and or a licensed psychologist involved for kind of life skills management, and then psychiatry, the MD for, you know, medications, but that PhD, that counseling aspect as well. Here's another illustration by the lady or man, Mr. and Mrs. Cross, Sean Cross, about what bipolar might feel like. And again, unfortunately, so bipolar comes on this big spectrum as well. Sometimes they're depressive episodes, sometimes they're manic episodes. The cycles aren't as quick as you would think. It's definitely erroneous, if not insulting, to say, oh, someone's just being bipolar. The word you're looking for is capricious. If they have a rapidly changing mood and attitude, they're being capricious. They don't have mental illness. Saying someone is acting bipolar is not correct, medically or politically. Again, the word you want is capricious. But rapid cycling bipolar is literally only 4 episodes or more, but that's still a change from a depressive episode to a manic episode over the course of months. It's not, and that's rapid cycling. So again, why that term is incorrect. We see a huge amount of suicide here, unfortunately, and there's a lot of accidental injury, especially in the manic periods as well, because of risk taking. So there's a lot of death associated with bipolar disorder. And we see it in young children, but we also see it in older adults. A quarter of cases are ongoing in older adults older than 60. But about half of them have cognitive impairments, not least of all because of its association with twice the risk of dementia. So there are some cognitive connections as well that even outside of dementia, you see, even when they're in a stable mood, that impacts their ability to interact with the world, hold down a job, pay attention, maintain relationships. And this isn't because they're, you know, again, I'm using this term, but they're not stupid, they're not slow, it's not an IQ problem. It has to do with their mental illness. And some of these, which it's kind of newer research, is how they emotionally interact with people, their ability to like read faces and detect emotion, and thus recognize, you know, someone as safe, like they're in that person's intent, is impaired, which means they might make risky decisions or more prone to exploitation because they have difficulty identifying who's trustworthy and who is not. Unfortunately, especially in manic episodes where they are not holed up in their home, depressed, they are more prone to law enforcement encounters, not just because they are the perpetrator of violence, but because they are also the victim of violence. And again, most of the arrests, if it's going to happen, it's happening during a manic episode, again, where they're making risky decisions. You get increased rapid cycling, increased speed at changing between a manic and a depressive episode as you get older. So that's something to know. And then, of course, the risk of dementia increases then. Because of the numerous factors contributing to mortality, the life expectancy is actually reduced in those with bipolar, and especially so when it is poorly managed and the client or individual is poorly adherent to the medication and treatment plan. Now, depressing stuff out of the way, 70 to 80% of people have a great life, good life, normal function, won't even cross our paths. So it's not all doom and gloom. Much as with schizophrenia, you want to do everything you can to maintain interpersonal relationships. That stability is important. You want to help them function by having them involved with people that they draw support from. You want to make sure their caregivers are well supported too, so no risk of mistreatment there. You use those long-acting medications if available to manage symptoms, and employ everyone you can to get help. You want these multidisciplinary teams, whether that's a psychiatrist, a psychologist, social workers, case managers, whomever you need, because when they are well supported, they really can, one, have a very normal lifestyle, even, and again, might not be appropriate for guardianship for long, but if you celebrate who they are in society, they will do better. Again, treat them like people. But from a practical standpoint, poor sleep can trigger mania, so maintaining good sleep is important. This is especially true in postpartum women who may be breastfeeding. A lot of sleep disruption from a new infant in the house, especially for women, but also for those dads. So making plans for those kind of settings is important. Minimizing substance use, which lowers your inhibition at baseline. You really don't want that in someone who's prone to mania. And then just making sure other psychiatric illness that might be existing concomitantly is also managed. Again, taking care of the whole person through disruptive times in life, through stressful times in life, like if they have a big project at work or if they're having a fight with a friend or family member, just recognizing that those challenges are going to be harder than average. So here's the overall prognosis. The people on the red side of the scale over on the right are the ones that are going to linger in guardianship. And as you get closer to the yellow, these are the people we might never cross paths with. And everyone else is kind of in the middle. So things to think about, your wards diagnoses when you're thinking about if capacity restoration is possible. So how do you test it? Real quick. Well, you want to see if the capacity for improvement is possible. This has to do, again, with the diagnosis as shown on this slide. And the associated prognoses is already covered. You want to consult with the experts for their conditions on their healthcare team to get a recommendation in that regard, because not every case is the same. But for those that you think after kind of doing these preliminary steps, there's an opportunity for improvement, growth, and learning, you want to give them an opportunity to demonstrate, just like this kind of graduated independence that, again, not meant to infantilize any of our adults, but in the same way you give like a preteen or a teenager increasing independence, you want to do the same thing. You take it slow, you give them supervised opportunities where there's safeguards and backups and they have the ability to reach out, but you prepare them for it by having these hypothetical conversations. What would you do in this case? If they can give a good plausible hypothetical, maybe try it out. Maybe go with them to the grocery store and let them go shopping for themselves. Maybe on the next time, increase the task difficulty, give them a longer list, give them, cash to make change, sit in the car while they shop, watching the front door to make sure no one wanders off, like increase their ability. And at some point, you'll either find that they're capable and don't need you a guardian at all, and applying for restoration of guardianship is appropriate, or you might find that it's overwhelming and they're not ready then or ever. So I coined this thing called the 4 S's. You want to, when you're testing them, make sure that they are safe. You want to make sure that they are adequately supervised. You want to schedule it. No pop-in visits to be like, hey, we're going grocery shopping today. Put on your boots. Let's go. Like, you want them to feel secure. And you limit the scope to one skill. You don't set them free and see what they can do for a week. You test one skill at a time so you can better identify where their strengths and weaknesses are and see if maybe a partial guardianship is appropriate, even if they're not totally independent. If they do well, celebrate, obviously. And if they don't, that's fine. Reassure, commend them, try again at a better time or in a different way. I get my groceries off of Instacart. I am capable of going shopping, but there are multiple ways to manage independently, and it's not one size fits all. So be creative. If they're really doing well, that's when you can start thinking about being a little more spontaneous and seeing how they adapt in novel situations. And the example I always give about adaptation is if you, in the middle of this presentation, your phone's blowing up because you just got word that your electricity is going to get shut off 5 days starting tomorrow morning. What do you do? Well, other than mildly hyperventilating and freaking out, I assume all of you guys have started abstracting. You are making up this hypothetical scenario of what you do. You book a hotel, you call your family, you pack your bag, you get a dog sitter, you pack your medications, your kids' clothes, you lock your doors, you make sure your oven was off. You do all these things necessary to adapt to the scary new situation that was sprung on you, because you have the ability to think hypothetically, and then executive function, that frontal lobe function, plan it out. You can do all of the steps necessary. You all know how to arrange for yourself in this hypothetical, disruption to your routine. If you're incapacitated, you can't do that. That's the key. Incapacity is the inability to function in your normal, but especially in novel situations. Some actions are stereotyped. There are plenty of older adults who can hard boil an egg every day for breakfast. But if I stuck them, I don't know, in a new setting, they would not know how to go to the store. They would not know how to find the store or, purchase the pan, whatever. They wouldn't be able to adapt when I take them out of their comfort zone. And being able to adapt outside of your comfort zone is an important part. That's why children, even if they can do basic stuff for themselves, aren't considered to have legal capacity, because children aren't as good, because of lack of life experience more often than not, to adapt to these novel situations. So really briefly, and I'm going to end here, I believe, are just some kind of examples of how you can test ability to go shopping, kind of the steps you might want to be looking at. And again, I wouldn't necessarily do all of these at once, but if you take them shopping, maybe see how they interact, have them pay the first time. They don't actually buy the items themselves. They just, or take the items off the shelf. They just pay. Then the next time, have them get a small list of items and you pay. But test discrete skills that in composite, if they can do everything, suggest capacity in one area or another. Having them pick out outfits to see if they can dress themselves appropriately for different weather and outing situations or different events. Can they transport on public transportation? Do they need help? Do they arrive on time? Do they bring the adequate money? Can they prepare a meal from start to finish, or even just microwaving food? Again, different levels of skill are needed for different degrees of independence. Can they keep their house clean? You might just observe that naturally when you visit them. Can they take their medications? Are things up to date? Are there lab values that suggest they're missing doses? Are they making and keeping medical appointments? Do they understand the importance of it? Why do they take their medications? Do they know why and what for? Can they recite their medications? Can they pay their bills, call their bank, set up auto pay? All of these things. And then safety, 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 safety. It goes without saying. Ultimately, be patient. I think I've said this plenty, but they are people, and it's important to focus on their ability. It's not that they are bad people. It's not the fundamental misattribution error. They are capable of doing a lot, and sometimes circumstances make it harder for them to do things, just like us. It's not that they're bad or stupid or somehow just disabled. There's a lot more that impacts an ability to do something. So building rapport, encouraging them to feel safe and secure can minimize the risk that they're going to kind of lash out and act badly or inappropriately. And you do this by focusing on their ability, really building them up, because ultimately, kind of catchy, but you can't have disability without ability first. So here is a summary of the fact that we talked about normal aging, how it's not, doesn't involve disability and incapacity. There's many things that go into aging that can make it abnormal. Sometimes those are permanent, sometimes they are more significant, but other times they are in a situation where restoration of capacity is possible. So guardians and those involved with wards can take steps to maximize this function. With training and practice and teamwork, it's important to remain vigilant for those who can and will improve. Guardianship shouldn't just be a de facto, dare I say, life sentence. And you can help your wards determine what they're capable of by testing them in safe, supervised, scheduled ways that focus on a narrow scope of function until you have enough information to see if restoration of guardian of capacity is warranted. You are welcome to raise hands, unmute, ask questions, anything, but that's also my email. Please feel free to reach out. I love to do it. I'm sorry, we came right up at the 2 hours. There's a lot to say. Go ahead.
Thank you, Dr. Heiner. I think everybody can see how, we usually see the physicians, psychologists in these cases from, miles and miles away from where they are. This is a great opportunity to be one-on-one with somebody who has an immense amount of talent and also great practical examples and helpful suggestions. So Q&A, we can take your questions if you'd like to come on. Anyone have anything that you want to say or ask about? It's I know it's a lot of content, but this is your chance to interact with Dr. Heiner. Let me ask while we see if anyone else is going to make a comment. So even in Brazos County, I think that we are like the 11th largest metropolitan area in the state, but we don't have access to geriatric psychiatrists. We don't have access to geriatricians. We have to go at least 100 miles to Austin or to Houston to find somebody who will come and do an assessment. And there's one out of Houston that we've been able to find, a psychiatrist who will do that. Do you have suggestions for those people who are in those parts of the state that do not have ready access to somebody like you in Harris County? What do you suggest can be done in order to get the best quality of assessment and I guess adjudication of a person's rights from a medical perspective?
Absolutely. Well, certainly not so shameless plug. So the Forensic Assessment Center Network, we offer telemedicine capacity assessments throughout the state of Texas. They are facilitated on behalf of Adult Protective Services. So in cases where there might be concern for like self-neglect is kind of one of the easiest ways that APS gets involved. Certainly communication between APS and the guardian about, the need for a capacity assessment to improve that individual's life is possible. Again, for every district in the state of Texas, FACN, Forensic Assessment Center Network, in partnership with APS, we do assessments of capacity routinely. So that's one option that literally comes to the patient or the client's home. Similarly, other telemedicine options might be